the intensity modulated radiation therapy. So last class we have seen the different type of steps like immobilization, acquiring of images using different modalities, and converting the images into a 3D, and the volume planning and dose planning. Okay, these are the steps we have seen in the last class. So today we will get into the next step, the step 6, which is called it as the conformal planning. Okay, so in the conformal planning we have two types of planning methods. So one is the forward planning and another one is the inverse planning. Okay, so in intensity modulated radiation therapy, these two types of planning has been implemented. Okay, so in the first category of forward planning, okay, so here when the beam is delivered, okay, so the tumor place, so it always spares, okay, spares or minimizes the dose of the healthy tissue. Okay, the ultimate aim of the beam, the collimation, is that the minimum normal tissues or healthy tissues should not be affected. Okay, so that is the main objective of the planning. Okay, forward planning. And in inverse planning, I take the respective result. Okay, yeah, a uniform target dose is planned, and we will plan in a reverse way. Okay, plan in a reverse way to do the beam intensity modulation. To understand that, you just imagine a tumor size is 3 mm. Okay, 3 mm. We can't define the shape. We just understand that it is like a circular shape, 3 mm. Okay, so in the forward planning, what we do is, according to that 3 mm tumor size, we design the beam, the intensity, so that the minimum health tissue damage can be followed. Okay, in inverse planning, what it does is, we plan the dose for the treatment, what are the dose required for that 3 mm, and then we will go back and we will the intensity is modulated based on the value of the dose. Okay, so these two planning methods are very important. So we do the first case, the intensity is done first, dose is minimized so that the healthy tissues will not be affected, and again we, after the feedback, we again increase the dose and we accordingly do that. In inverse planning, the dose is confirmed, based on the dose the intensity is modulated. Dose means the radioactive isotope dose, what is the dose level for the tumor reduction. Okay, so that is what the next is, the treatment volume. Okay, when you say yes, the treatment volume, that is also it's about the what is the, okay, the next is the treated volume, the previous treated volume. Okay, so volume enclosed by a dose level, dose surface, which is specified by the oncologist. Okay, when you see this diagram, you can find that there is a marking, okay, which looks like it has been marked with a free hand. So there is a tumor out there, and in the tumor the treated volume and the irradiated volume are marked. Okay, so the treated volume is the volume where which the oncologist marks it, okay, where the beam is being focused. In irradiated volume, that volume is about the marking where the possibility of the radiation is applied, and the normal tissue should have a tolerance to handle the beam. So what they will do is, in the irradiated volume, in the treated volume area, okay, for example 2 centimeters square is the spot, means they will shrink it to 1.5 centimeters square. Okay, so you can find that the treated volume area will have the dose or the beam intensity more compared with the irradiated volume area. Okay, that is very less in the irradiated volume area. In that, the treated volume area will be receiving the maximum dose level. Okay, that's what we call it as the PTV, planning treatment volume, treated volume. Okay, that is the way the oncologist will plan so that the tumor will be under the radiation. Okay, so this is the just to have a difference on how the things has been marked. Okay, so first is the conventional radiotherapy. There is no idea about the tissue area. For example, if you take this diagram, there is an irradiated volume and a treated volume. In this diagram, you can find that the markings are like a free hand. Okay, when you see this diagram, you can find that it is square in shape. This is the right. This is the way the beams will enter the patient from the collimator. Okay, so here we have a square type, so we can see that larger area will be come under the radiation beam. Okay, so next is when you see the conformal radiotherapy, that is what we have seen in the previous classes. Okay, CFRT. Here the tumor value is marked, which is very similar to the diagram which is given here. That is the treated volume. Okay, treated volume, and we have an irradiated volume. In the treated volume, there will be a tissue, and we get the conformal radiotherapy. Even intensity beam will be applied. There is no intensity modulation. Now we are looking at intensity modulated radiation therapy, where based on the tumor strength, the intensity is modulated. Okay. So when you go for the third one, we can find there is a the tumor is been marked with a dark black, okay, like a stripes, which shows that the beam applied to the tumor is varying. Okay, you can see that the things are getting varying, not constant, which means that the IMRT, where intensity is modulated based on the tumor level and the dose which has been chosen. Okay, this diagram you can easily draw in the exam. Okay, if you ask a question like differentiate between or compare, okay, compare the conventional radiotherapy with the CFRT and IMRT, if the question is asked, you can able to draw it. Okay, so this is another perspective. You can see that in the 3D conformal radiotherapy, you can find that there is a tumor in all directions. You can find the arrow marks shape are same. Okay, that is the target volume to represent this diagram. In the exam, it is, you can ask a question like explain in detail the how the treated volume is being defined. Okay, in IMRT when compared with the 3D CRT, that is what you can ask. Question can be asked, or a question can be asked like compare the treated volume in 3D CRT and IMRT. Okay, you can write out the definition and draw this diagram, and to support you can draw this diagram, which is very easily understandable. You can find that there is a tumor and in 3 directions. Okay, this is a simple analogy we have followed it everywhere when there is something which is sphere in a shape. Okay, so we need at least 3 beams required to occupy the or cover the maximum area. That is what even in satellite communication, to cover the entire Earth, we need 3 satellites. Okay, now you can find that in 3D CRT, the beam, the arrow mark, okay, the arrow mark is the beam. You can find that the arrow marks remain constant. Okay, so which shows that the beam applied to the tumor is constant. When you go to the IMRT, you can find that the beam entering at different places are completely different. Okay, so that is what you can find that in the 3 directions we have the radiations beam, the arrow marks are different. At the top you can find that it look like a sine wave, while the other 2 places you can find that there is a increase in the beam and it reduces. Okay, that is what you call it as the intensity modulated radiation therapy. Okay, so for different area of applying the beam, the radiation beam alone gets modulated. Okay, so that is the comparison pictorially represent. Okay, so you can easily draw this. That's what the treated volume, that is the area where the oncologist marks here. Okay, this is a treated area, very small. You can see that the size is little bit bigger tumor, 1.5 centimeter square. That is the treated volume area. Okay, so the tumor, this is nearly some 15 millimeter. Okay, so 15 millimeter. So if you take this diameter as a 15 millimeter, as I said, the tumor size will be from 2 to 4 millimeter. Okay, the shape is undefined. You can see that the tumor shape is undefined. We can just round it off like a shape. That's it. Okay, it varies. Okay, the tumor growth, even though it is it's slowly grows in all directions, but there is also a non-uniformity, the tumor growth. Okay, so it changes from patient to patient. Accordingly, the dose level in the IMRT has to be monitored. That is what we have seen in the last class. Okay, so to just summarize some of the concepts on IMRT, where we find that a non-uniform beam is being delivered to the patient, and the position also is to be optimized based on the dose level, dose distribution. Okay, dose level and dose distribution. That's what in this diagram you can find that the tumor is more at the top side, and the sideways and the bottom it is less. Okay, so that is what the meaning is: ununiform fluence or intensity, and the position of the patient is kept proper, and the dose distribution is made optimized. That is what you can see that in IMRT, the bottom two sides, the distribution is different when compared with the top one. Okay, so that is what the IMRT book. Okay, so that is this is extensively used in the treatment of prostate cancers, head cancer, and head tumor and neck tumor. Okay, and CNS. In central nervous system, also there can be clots. Okay, and bulges in the nerve, so that is also can be treated. Apart from that, in gynecology, malignancies, thyroids, lungs, and breast cancer also, IMRT play a vital. Okay, so this intensities, okay, this intensity can be modulated by using wedges and compensators. Okay, so the treatment criteria mainly focuses on how to optimize the intensity level by which the dose concentration or dose distribution has to be properly monitored based on the strength of the tumor. Okay, these fluence files, okay, the intensity files, what is the beam to be applied on which area, which is computer controlled, and it is given to the LA. Okay, Linacs. In few books, linear accelerators are shortened as LINAC. In few books, it is being shortened as LA. Okay, there's a lot of abbreviations. It's very difficult to remember that in the first time of reading. But I always urge you people in your notebook, try to write all the abbreviations. Okay, because in the exam they used to ask it like, what is an LA? Okay, even though you know about linear accelerator, that you can unable to recover that during the exam. So what you do is write all the short forms or abbreviations in your notebooks, so far it will be helpful for during the exam. Okay, this is completely computerized. That's what a biomedical engineer is required for coding and everything, because the beam distribution is very, very important, which is manually it's very difficult. In olden days, Linacs, that is what done manually. Okay, but now efficiently computer control is used, so the modulated beam can be properly calculated and delivered. Okay, so the physical aspect, the IMRT combines two advanced concepts to deliver 3D CRT. Okay, conformal radiation therapy. So that's what like this we have an abbreviations everywhere in the subject. You can find a lot of abbreviation. Okay, then ITP, they will say that ITP, CCIM. Okay, how it will be very difficult for you people to remember everything, but when you read again and again, and write it in the note on all the abbreviations, because these even in the classes we have seen that lot of abbreviations are coming in. Okay, so this especially you may find abbreviations like PTV, okay, planned treatment volume, okay, treated volume, like that we get many things. So now is the another abbreviation ITP, inverse treatment planning with optimization by computer. We had two type of planning. One is the forward planning, another one is inverse planning. Okay, in inverse planning, we take the size and shape of the tumor. That is what we have seen up till the step 5 in the previous class. How that tumor volume has been calculated. That is what we have seen, the steps. By using modality CT scan, MRI, we do that. And after that, we calculate the dose required for the complete tumor intensification. Okay, so that has been done in the planning, inverse planning, and after that only the beam will be modulated. So computer controlled intensity modulation of the radiation beam during the treatment. So manually it's impossible to do that if the tumor size is very small. If it's a large size, you can approximate, but that is dangerous because here there is a radiation may affect the normal tissue. So normally we go for the computer control, where even the minimum information about the tumor can be monitored by MRI or CT, and that images will be converted into 3D. In the three-dimensional view, what is the dose required that has been planned, and it has been given in the unit of gray. Based on the dose, the intensity will be modulated in ITP. Okay, so a simple question about the tumor question. What is an ITP? Inverse treatment planning. So a tumor 2D is converted into 3D by using MRI or CT scan. After that, based on the shape and size of the tumor, the dose distribution will be done. Based on the dose distribution, the intensity beam is modulated. Okay, that is the explanation for ITP. Another one is FP, forward planning. That is completely reverse. What I said, first is the intensity is being modulated and applied, but the dose distribution is kept to minimum. If in ITP we choose a gray level of 50, means 50 gray. In an FP we choose a 20 gray. Apply the intensity, take a feedback, and accordingly the dose level can be increased. So these two things in the forward planning and the inverse planning, the computer hand is very high. More, you can say that more, the computer involvement is more. So, okay, so first is the based on the inverse planning, as I said just now. CT scan is performed on the affected region. Okay, so the radiation oncology defines the PTV. That's what I said. There is a lot of planning of treated volume, PTV. Then they go for a plan criteria. So the plan criteria goes for what is the maximum dose, what is the minimum dose, what is the desired limiting dose for critical structures. Okay, and the dose volume histogram, DVH. That is another abbreviation, DVH. So you should be, that's also you can note it down. Okay, next is then an optimization program is run to find the treatment plan which best matches all the equipment. Okay, so the optimization program consists of the dose level, the PTV. Okay, we have planning treated volume and planning irradiated volume, PIV. So so we go for a planning treated volume, planning irradiated volume, DD, dose distribution. Okay, DVH, dose volume histogram. These all combined together, we go for an optimization program. In the program, makes the best match of the intensity for the dose and PTV, which is done already. Okay, so that is the planning. Okay, so we have a gray level monitoring. Okay, the goal is given and the value below goal, and the minimum gray level obtained and the maximum gray level taken. Okay, this is the actual hospital data. Okay, then is the sensitive structure names. Everything is mentioned: tissue, heart, kidney, lung, liver, right kidney, right lung, and spinal cord. Okay, all the organs and their tissue which can accept the radiation isotope gray level is given. Okay, so that is limited. The gray level you can find easily that the normal tissues can handle 49, while the lowest is being taken by the right lung and the left lung. Okay, they can have the limited gray level. Okay, so this is just a understanding of how the planning is being done. Okay, so the planning of the once the 3D is done, the treated volume is measured. Okay, after that the dose level is tabulated like this. What is the gray level, everything the oncologist will determine based on the tumor critical stage people. Okay, that's what it's given us for critical structures. Critical structures means which means the tumor will have a very irregular shape and size. Okay, that's very difficult. If the tumor shape is something very close to a shape, so like a spherical or something like that, it's very easy, you can confirm the PTV. But if it's not a regular structure, then the dose level has to be properly distributed. Okay, distribution means there is a tumor and at which place what is the dose level applied. Okay, that has to be done. Okay, this is called as a dose volume histogram. So we can't see the numbers here, which is not little clear. Okay, so just you can understand that the dose distribution, the color gives the dose distribution in a graphical 2D format. Okay, so we have a tumor and the dose level has been given with the color values. Okay, and what are at what places, what is the dose distribution to be applied. Okay, that is what we call it the histogram. So the 3D, the first step. Okay, the CT scan is performed and the 3D we obtained. So from the 3D, okay, once the dose level is confirmed, the dose distribution graph is that how in the tumor, what are, you can see that how the three images in the right corner, you can find that how the tumor is marked. There is an yellow marking around the tumor. You can see the tumor shapes. The tumor shapes are very irregular. Okay, so and another very important thing is it's very difficult to convert a 3D into a 2D. For image it's okay. So that is what, to represent a 3D dose distribution, okay, in 3 directions X, Y, Z, they are differentiated with 3 directions, because we are going to apply, just you imagine this 3 image. Okay, you imagine the 3 image is a photograph taken from this 3 side. Okay, this is the IMRT image or the 3D CRT. You can see that we have 3 directions X. We just imagine this X and this Y and this is Z. Okay, from the center you can draw the upward is Y and the right hand side is X and the left hand side is Z. If you take it that way and you are placing a camera, and you can just imagine that you are taking a 2D photograph, okay, of this tumor at 3 direction. Okay, hope you understand. So this 3 directions, and you can able to picturize that. Okay, now you can easily understand the dose distribution from that. The depth is unknown. That's a very difficult task. That's very complex, the depth. Okay, but you can approximate. Okay, approximate the depth, and by continuous study of the MRI CT images, the oncologists can come to a conclusion that the depth is this much and this much dose is required. Okay, that is what you call it as the dose volume histogram. The treatment planning, the inverse planning methods are divided into analytical method and iterative method. Analytical means you will be very confident on this is the dose, this is the beam intensity, and this is the histogram level, so we will be going for the treatment. Okay, that is very analytical. Iterative means reduce the dose. So reduce the dose do the process and take a feedback and check, okay, it's okay, then you will go for it. So that is what many computer programs has been used for the intensity beam modulation. Okay.